So I'm going to introduce our speaker, Jennifer Shannon. She's the author of the Shyness and Social Anxiety Workbook for Teens, CBT and ACT skills to help you build social confidence, and it's published by New Harbinger Press. She has over 25 years of clinical experience and specializes in the treatment of social anxiety in children, teens, and adults. She's the clinical director of the Santa Rosa Center for Cognitive Behavioral Therapy in California. Jennifer Shannon is also a certified diplomat of the Academy of Cognitive Therapy and a graduate of the Behavioral Therapy Training Institute for Advanced Training in Obsessive Compulsive Disorder. Welcome, Jennifer.
Thank you. All right, so does the sound quality sound good? About right? Okay, good. So let me start by telling you a little bit about myself in addition to what just heard. This is me in preschool, and I was a very shy child. And that shyness manifested in not liking to be called on in class, and I would rarely raise my hand if, even if I knew the answer. But it didn't interfere with making friends or things like that. I always had friends, but I preferred one-on-one as opposed to like big groups of people. And then, that continued on. And I never really felt like it interfered with my functioning, but it was interesting because when I was in my master's program at Sonoma State, one of my professors said that she felt that I was withholding. And I thought that was interesting because I hadn't perceived myself as withholding. But what I realized is that I would usually draw other people out and not say much about myself unless I really knew the person or was comfortable with them. And it really wasn't because I was aloof or withholding, it was because of that shyness of like, I didn't want to say things and have somebody maybe not seem that interested in what I had to share. So I realized that subtly my shyness had been, kind of interfering with my interpersonal relationships a little bit. And so I made myself an assignment, and that was that every day I was on campus, whenever I was in a conversation with somebody, I needed to share something about myself. It was just like an assignment, like I needed to do that. And it didn't have to be a big, revelation. It could be that I went to the beach or a movie I saw or something like that. But that helped me just kind of overcome that kind of what was perceived as withholding, and it was, but it was really because I was shy. And oftentimes shy people do come across as being a little bit aloof. And it's not that they are, it's just that that shyness comes through. So I have 3 children, and another part of where I came to write this book, actually, I started doing cognitive behavioral therapy probably about 12 years ago. And so really just, it was a good fit for me. I'd been doing more psychodynamic therapy, but when I kind of started learning CBT, it was like, oh yeah, this is really what I'm interested in. And I was very interested in working with anxiety disorders, and I know anxiety up one side and down the other personally, and so it was fun to work with people with that. And so I have 3 children, and they're all actually, well, 2 of my boys were shy. In fact, I used to do little things like say, okay, when we're at swim team, you need to make eye contact and smile and say something. And I'd actually do little rewards for them when they did that to kind of push them over that kind of shy hump. But my daughter wasn't shy at all. She was very outgoing, very confident, really popular, had tons of friends. But what happened, I thought it started in 7th grade. She said it started in 5th grade. And this is the age of onset. She developed severe social anxiety. Hadn't had it as a young girl, but in middle school, which is typical age of onset, she did develop it. And first it came with she didn't want to go to school. And I was like, this is interesting. And so, of course, I didn't allow that. I said, you have to go to school. And so she would go to school, and then she started getting stomach aches. And then she started telling me she didn't have friends. And she told me she hated lunchtime, and she hated recess. And so I'm slowly, as we're talking, I'm starting to get that she is really developing social anxiety. She feels like people aren't interested in her, they don't like her. And this was the farthest from the truth as could be, it's just. And it got more intense, more intense, more intense, until one day, as I was trying to get her out of bed, she said, "I'd rather die than go to school." And she was 13 at this point, and I couldn't physically get her out of bed. So she was a school refusal kid. And so now I'd already been working with this, but she, good for her, said she didn't want me to be her therapist. And it was actually challenging for me to find a therapist who did the kind of CBT exposure work that I'm going to be talking about tonight, or today. I keep saying the night. The last presentation was at night, so I guess that's in my brain. And so we had Kaiser, and she went to Kaiser, and she got some therapy, and it was somewhat helpful. But I thought, if there's a book so she can know she is so not alone here. And when I started looking for books for social anxiety for teens, there wasn't anything written. Now, there's lots of social anxiety books for adults, but not for teens, which is so odd because that's the age of onset. So I very passionately wrote a book, which is and I have copies if people are interested in it. It's called The Shyness and Social Anxiety Workbook for Teens. And I wrote it in a way that I wanted to make it not at all patronizing, something that teens would relate to, read easily. My husband's an incredibly gifted illustrator, and so he did a lot of the illustrations, so it's not only words, but it's, kind of more images and cartoon sequences and things like that, which make it interesting. So that's how I came to write the book. And in addition to that, I am the clinical director of the Santa Rosa Center for Cognitive Behavioral Therapy. And there's 3 licensed therapists, and we have 2 interns, and we're actually growing our internship program. So if you know of interns who are interested in intensive CBT training, let me know. And in fact, along those lines, I didn't bring enough cards. Like, I was talking to Denise, and I was like, oh, where's my cards? If people are interested in learning more about the center or want any follow-up, leave me your card, and then I'll just do a little email thing to you if it has your email on there. And I guess the cards could be left up at the table or on the desk or something like that. Okay, so who are you? All right, now, do we have a list of how many people are in the room right now?
How many?
Yeah, because we're going to do a little math, and I'm not good at math, but is in the list, because people signed in, right? Oh, there's not. Oh, okay. Can somebody do a count? 47? Wow. I don't think I brought enough handouts.
Just raise our hands and count.
Well, no, it's okay. Let's think. Oh, I wish it was an even number, like 40. Okay, let's 45 or something. Okay, so here's what I want. No, don't leave. Okay, so here are your choices, all right? Now, what I am going to do, if you're comfortable doing it, if you're too shy to raise your hand, that's okay too. But if you would, I'm just going to only raise your hand once for each one of these. Figure out which one of these you think applies best to you. If you would say that you consider yourself shy, where it's a part of a kind of a problem, and in some situations, previously shy. Oh, well, that's sort of shy. Okay, well, one's more problematic than the third one. Okay, so just kind of think of where maybe you are in that. And then I'm just going to, so how many people, raise your hand if you're in the first category. 1, 2, 3, I put myself there, 4, 5. Okay, 5, so we think of that, 5. So, could somebody write that down, 5? Okay, on the second category, raise your hand if you're in that category. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 14. And then the third category? Go here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 25, 26, 27, 28. 28. And then the last category. 1. Okay. All right. So then, did somebody write all those numbers down? Because then we want. Can you like to get a percentage right? You would do the number divided by another number. Okay. So just kind of maybe could you get a percentage of like the room? Could somebody do that? Okay. Hal's doing that. Okay. Thanks.
Yeah, right.
27%.
11% is in the first category, 30% is in the second category, 60%
Okay.
in the third category.
So either you guys are not, this is unusual actually, very few people raise their hand. Usually, I've done this several times, and usually the room is very representative of out of 1,000 people. 40% usually would say they're shy to the point of it being a problem. It's really common.
We're more self-accepting group, maybe? I don't know.
40% said they were previously shy. What was our percentage?
Yeah, what was the number 2 percentage?
We had 11 for the first.
It was close to 20%.
20% less. And 50% shy in some situations. Here it was like practically 60%. 5% said they'd never been shy. What was ours? What, does that make it 1%? 2%. Okay, that's unusual. All right, so but anyway, that's the national average. And see, my theory is actually that therapists are a shyer group than most people. But you guys just blew that theory. Well, regardless, it's very common.
But
So
this was amongst people in general across the nation.
yes, exactly.
And
Not an inpatient population or something. No, it was, yeah. Okay, so approximately 12% of the population would meet criteria for social anxiety disorder. Oops. So it's the fourth most common problem. You know, it's interesting too because, of course, with social anxiety, it's often comorbid with depression. And as well as for substance abuse. And alcohol would be the substance of choice because it's a disinhibitor. And then specific phobias, yeah, as far as anxiety, but that's a big, large category. So it's extremely common. All right, so what I'm going to do is, this is one of the things I'm working on, is not talking too fast. Even though I got a later start than I had, so my time is like, I'm a little methodical person, and but I'm not going to talk faster because of that. And if I do start talking fast, I would love feedback. If you could just go like that, like slow down, because it's the thing I'm really trying to work on when I'm talking. All right, so I'm going to go over the CBT model, what maintains social anxiety. Today I'm going to be focusing on cognitive interventions. The behavioral is extremely important, but the cognitive sets the table for behavioral. So it's really important as well. Troubleshooting, and if I get to it, other applications. All right. So Charles Schultz, our very own Charles Schultz, he either had social anxiety disorder or he knew it very, very well, because this is pretty much, this is the DSM, really. This is, okay, oh, how I hate these lunch hours. That is a very common time. It's not a structured time. Always have to eat alone because nobody likes me. Peanut butter again. I wish that little redhead girl would come over and sit with me. Wouldn't it be great? She'd walk over here and say, "May I eat lunch with you, Charlie Brown?" I'd give anything to talk to her. She'd never like me, though. I'm so blah and so stupid. She'd never like me. I wonder what would happen if I went over and tried to talk to her. Everybody would probably laugh. She'd probably be insulted, too, if someone as blah as I am tried to talk with her. I hate lunch hour. All it does is make me lonely. During class, it doesn't matter. I can't even eat. Nothing tastes good. Why can't I eat lunch with that little redhead girl? Then I'd be happy. Rats. Nobody's ever going to like me. Lunch hour is the loneliest hour of the day. Yeah, so if we look at the DSM, the individual fears that they will act in a way that will be embarrassing or humiliating. People would probably laugh and be insulted that someone as blah as me. Almost always, the feared situation almost invariably provokes anxiety. It's lunch hour for Charlie Brown. Oh, that's when he feels the most anxious. Recognizes the fear is unreasonable. Charlie Brown probably didn't recognize that. Situations are avoided or else endured with intense anxiety. He ate lunch by himself. That's very common. You'll hear kids talking about eating lunch in the bathroom or in the library. Interferes significantly with normal, routine, functioning, social activities. I always have to eat alone. So he's alone. He's isolating himself. So it's socially interfering with his functioning. All right. So if you think of it just really, it's a fear of doing something embarrassing or looking foolish, being judged, criticized, disapproved of, rejected. Just that's what the core theme of social anxiety is. All right. So I do a lot of assessment, and for a lot of different reasons, because with anxiety, of course, oftentimes people often say, okay, well, I have anxiety, but I want to know what type of anxiety they have, because anxieties have it falls into different categories. OCD is very different from social anxiety disorder. Separation anxiety is different than panic disorder. There's all have their different core fears, and oftentimes somebody will have more than one anxiety disorder, so I want to know that and figure out what are we going to start treating first, because if we try to treat everything, it's going to be challenging. So this is a really nice, and this is in your bibliography in your handouts. This is a really nice, of course, it needs to be updated because it's DSM-4, but it's a really nice, you can do it as an interview in session, and there's one for kids and one for adults, and it's not only anxiety disorders, but it has other common comorbid disorders with that. This is the one I'm really into these days, and we're going to actually use it today. It's the Leibowitz Social Anxiety Scale, and the reason I'm really into it is that it has two different things it's looking at. It's looking at different situations you're anxious about, but it also has a separate category for are you avoiding those situations? Because that's where it interferes with functioning. It's that avoidance component of it. If you're doing it and you're, able to still engage, it's going to be less of a disorder for you than if you're not doing things. So it looks at both of those things. And you also have this in your handouts. So this is just an example of some of the type of common situations that people feel socially anxious. So I'll show you in a bit how I use this. I use it not only in assessing pre-treatment, where are they at? So I'm going to be treatment monitoring, are we getting changes in this over time? But it also helps me identify their goals. What do they want to work on most? What are the areas that they're avoiding? And what's important to them to work on? They might have things they're avoiding and that's not important to them. I'm not going to work on that. I'll work on the ones that are important to them because they're going to be more motivated. And it's a challenging therapy, so they need to be motivated. All right. The other one, it's a nice, really short one, is David Byrne's Therapist Toolkit, if any of you are familiar with it. It's a really easy one. You could do it every week. It doesn't take that much time. Okay. So why CBT for anxiety? Well, the cognitive part helps change kind of the way the person's thinking. And then the behavioral is helping change how they're reacting to that anxiety-provoking situation. So those two aspects are the kind of active ingredients in CBT. This is what I call the dog story, and I'm going to do it with you just like I do it with a client when they come in. And I do this whether it's a child I'm seeing. I see kids as well as teens and adults. And this is how I explain cognitive behavioral therapy, the model. And I'll keep referencing this back throughout the treatment. It's called the dog story. And my husband did the beautiful illustrations, and I draw stick figures on the board, so that's what my clients get. You get a nice, really fancy version here. All right. Yeah, if you're interested in it, I also have a YouTube video of me telling the dog story on our website, and that's our website.
Hi, my name's Jennifer Shannon. I'm the clinical director of the Santa Rosa Center for Cognitive Behavioral Therapy. When people come to me, they often want to know, what is cognitive behavioral therapy? And I like to best explain it with what I call the dog story. Once upon a time, there was a boy named Justin who loved to ride his bike. He'd come home after school, grab a snack, and take his bike out in the neighborhood. Well, one day he was riding his bike, and a neighbor had left their gate unlatched, and their mixed shepherd dog came charging out of the gate, chasing Justin down the street, knocking him off his bike. The neighbor heard the commotion, came out, grabbed the dog, and asked if Justin was okay. The dog hadn't bit him, but it had really shaken him up. The next day, Justin was walking to his bus stop, as he did every day. He was about halfway between his house and the bus stop when around the corner came a woman who had a Labrador Retriever on a leash. Justin stopped in his tracks. If you had to guess what he was feeling, what might you guess? He was probably feeling scared and panicky. What was he thinking? Well, he wasn't thinking that's a cute dog. He was probably thinking something more like, that dog might get off the leash and attack me. What did he do? He ran back into his house. I've asked 3 questions. What was he thinking? What was he feeling? And what did he do? What we think influences how we feel, and how we feel influences what we do. Cognitive behavioral therapy is based on the connections between thoughts, feelings, and actions. Once Justin was inside the house, his body calmed down and he didn't feel as scared and panicky. By avoiding the dog, Justin managed his anxiety. He felt safe. He didn't get bit, and in his mind it was because he ran away. Justin's avoidance behavior reinforces his anxious prediction that the dog would bite him if it had a chance, and this is the beginnings of a phobia. His belief that he must avoid dogs to stay safe reinforces the panic he feels each time he sees a dog, which makes him want to run away. It's a vicious cycle. Over the next few months, Justin saw about 12 dogs, and he reacted the same each time. He no longer would ride his bike in the neighborhood, he wouldn't walk to his bus stop, so his parents had to drive him to school, and he wouldn't go over to friends' houses if they had dogs. So his world was becoming smaller and smaller. If Justin wanted to overcome his fear of dogs, he would need to do 2 things. He would need to change how he's thinking, and he would need to change what he's doing. Cognitive behavioral therapy is designed to help clients do just that. The cognitive part stands for helping Justin to think more realistically about the actual danger of coming into contact with a dog. Fears and phobias are fueled by overestimations of threat. The behavioral part is to help Justin stop avoiding dogs and begin to face his fears. But it's not done all at once. Instead, it's done in small, manageable steps, sort of like climbing a ladder. Justin's therapy began with exposure to a small dog, which caused him big anxiety. But he learned that he was safe even in the presence of a dog, and this changed his thinking just a little bit. As his cognitive behavioral therapist introduced him to more dogs, he grew less and less anxious, and his thinking became more and more realistic. So how does this story end? Well, it's a happy one. Justin is again able to ride his bike in the neighborhood, he can walk to the bus stop, and he can go over to friends' houses even if they have dogs. Cognitive behavioral therapy is helpful with all sorts of fears and phobias, including social anxiety, generalized anxiety, panic, agoraphobia, obsessive-compulsive disorder, post-traumatic stress disorder, as well as things like depression and insomnia. If you'd like to learn more about cognitive behavioral therapy, please visit our website at srcbt.org.
If you had to guess how that made him feel, what would you say? Right. Anxious, nervous, absolutely. If you had to guess what he did, what might he do?
Go back in the house.
Run away, go back in the house. Yep, he did. Okay, so run away. All right. So now we've connected the dots. We connected the dots. Now, if he thought, that's a cute dog, and he felt scared and nervous, we go, wait, we can't connect those 2 dots because that doesn't make sense. But if he's thinking that dog might get off the leash and attack me, yeah, then he'd be feeling anxious. We've connected the dots. So we're always trying to do that in CBT, connect those dots. Okay. Now, once Justin was inside of his house, what happened to that nervous, panicky feeling? Do you think it went up or it went down? Down, exactly right. It went down. So here's the thing. Actually, wait, before I go to that. Okay, so it went down. So that behavior of going in the house is likely to be repeated because it worked. Anxiety is uncomfortable. It makes us think something's wrong. If we go and do a behavior that makes us feel less anxious, we're like, yeah, I'm going to do that again. Did he get attacked by the dog? In his mind, why didn't he get attacked?
ran into how.
Exactly. So the behavior is reinforced because it brings the anxiety down, and that behavior reinforces the cognition that had he not done this, he would have been attacked. So this creates a vicious, this is what maintains anxiety. Any anxiety. This goes for any anxiety. Certainly for a dog phobia. So we've got this whole thing. Yep, we see how it reinforces itself. And then his world starts getting smaller and smaller because now he won't walk to the bus stop. He won't ride his bike in the neighborhood. He won't go over to friends' houses if they have dogs. So we can see how he's repeating the avoidance and it's becoming worse. So his world's getting smaller and smaller. That's a disorder. It's interfering with his functioning. So if you were my client, I'd say, so gosh, now Justin's life, he's not doing the things he likes to do. What would he need to do to get over his fear of dogs? Any ideas?
Go to a pound and walk down the aisle where everybody's caged up and they can't get out.
There we go. So he'd have to face dogs. Maybe he could start with a pet store where the dogs are in cages. Beautiful. And I just let you know, what I just did with you, I can do with a 4-year-old, and they will give me the same answers. Really, I'm not kidding you. I've done this hundreds of times. So it's really amazing. And a 4-year-old won't get the sophistication of that, the thoughts maintained by the behavior. No, but they can connect these dots very easily. Okay, so yes. So because his world's getting smaller, yep, depressed, he could get depressed. So what would we do? And this is what we do in cognitive behavioral therapy, is we need to start facing that fear, but we build a ladder. So we're not going to start with the biggest, scariest thing. We're going to start with something small. So maybe it would be a small dog or a pet store or a picture of a dog, whatever it is. We create the ladder with the client and then move them up until he was able to overcome his fear of dogs, realize that not all dogs will attack me, and he can be back to where he was prior to the dog attacked him. All right, so that is how I explain cognitive behavioral therapy to my clients. So what anxiety disorders have in common is they always have any type of anxiety is an overestimation of threat. Because Justin was attacked by one dog, he's now thinking all dogs will attack him. You're overestimating that threat. Underestimate ability to cope with that threat. I get so anxious I can't stand it, I have to leave. So those two mechanisms are happening, and that's, if you think of it as like an equation, it equals anxiety. The other thing is, that's true with all anxiety disorders, is avoidance is always the behavior of choice. That's why they're coming to see you, because they're doing so much avoidance and it's causing a problem. All right. What makes social anxiety unique is the content, the theme, the core fear of that. So like if it was panic disorder, the core fear is usually something like having a heart attack, going crazy, losing control. That's not true with social anxiety. Although socially anxious people may have panic attacks, they're not usually, if you ask them, when you have a panic attack, what are you most afraid will happen? They'll say things like, people will notice me, it will be so embarrassing, I'll feel humiliated. They're not thinking I'm having a heart attack and dying. They might if they have panic disorder and social anxiety. But it's the content of the core fears that it's a theme of social threat. Okay, so if we're going to take a situation like talking to someone, which is something socially anxious people, it's probably the most common thing that they're anxious about. Talking to someone, then we want to connect the dots, just like we did with Justin and the dog story. Okay, so how can we connect these dots? They might say something like, I won't know what to say. Okay, so we've got a cognition, right? But it's not enough. Because a lot of people might think, I won't know what to say, and they're not that anxious about it. So I'm not yet at the core, I'm not at a core fear, I'm at the beginning. So I would say something like, if you don't know what to say, what are you afraid will happen? And they might say, well, he will think I'm stupid. I'm going to keep going. And if he thought you were stupid, what are you afraid would happen? And he might say they might laugh at me or reject me in some way. Now I've got a lot more of a nice cognition here because I've got more of a core fear. For one thing, it's more testable. And it also is we're getting more down to the fear. All right, and then of course we connect that to what they're feeling. And we're connecting it to behavior. Now here's another thing with social anxiety. So of course, the behavior is always avoidance. However, with social anxiety, that avoidance can be a whole array of behaviors, and some are quite subtle. So if he's saying, well, I don't know what to say, so he's going to avoid conversations. Okay, that's pretty obvious, right? He may not avoid conversations, but he would avoid initiating a conversation. So he'll let people come and talk to him, but he's not going to initiate a conversation. So that's more subtle avoidance. Or he might initiate a conversation, but prior to initiating it, he's going to think carefully what he's going to say. That is a form of avoidance. That may seem confusing to you, but what he's doing is he's avoiding the core fear. So his fear is that I won't know what to say, and then I'll be rejected. So by rehearsing things, he feels like then the core fear won't come true. And in fact, what that does is maintains the problem. Does that make sense to people, how that would maintain the problem? It's subtle, though.
And what happens to spontaneity in life, or quick changes, or the ability to be flexible?
Well, there's that, but it also maintains his core fear. See, if his fear is I won't know what to say and people reject me because of that, he's not testing it. So it will be maintained. It's sort of like if, let's say Justin was going up to a dog now, and he's like, yeah, I'm going up to a dog, but he's like still feeling anxious. He still won't go up to the bus stop. We're like, wait, what's going on? He's going up to dogs, but he won't walk to the bus stop. Something's going on. Well, he's going up to dogs, but he's not getting near their face, because that's where the teeth are, and that's where Justin's afraid that he could get attacked again. So what would we need to do is get him to touch the face of a dog. Because it's that avoidance that's going to maintain the anxiety if the core fear is that dog will bite me. If this is they'll reject me because I won't know what to say, we need to have him do an exposure for that, because this subtle avoidance will interfere with that.
I just found it interesting because I would have seen that as
A coping strategy. Exactly. We don't see it as a coping strategy. We see it as a maintaining a problem. If it worked, I would be fine with it. If that worked and my client wasn't anxious because of this, I have never seen this work. It may work in the short run, just like avoidance works in the short run, but his core fear is still always there every time he gets into a conversation with somebody, and it will limit his life spontaneity. It will interfere with that. Yeah. So that's where it gets into those subtle things that are really important, avoidance behaviors. Okay, so I want to have you guys do a practice. So I'm going to start with, if you could find your Leibowitz questionnaire, which is on the opposite side of your bibliography. And I'm going to just have you go through that. Enough of you, only one of you is not anxious in pretty much any situation.
not absolute.
Okay, not absolute. So I think everybody will be able to find something on this scale that makes them anxious. You don't have to necessarily fill out the whole thing, but what I would like you to do is choose something on that list that does make you anxious, and that you'd be willing to do a thought record with someone else on. So just look at the thing and see if you can pick something that makes you anxious that you'd be willing to work on a thought record on with somebody else in this group. Did everybody find something? Mm-hmm. Did anybody not find something?
I don't have a form.
Oh, I know.
I don't see any.
I know. I didn't realize so many people were going to come. Okay, you could maybe look at, because you could pick something off somebody else's. Yeah. Everybody else has got one though? Okay, so she can be looking at that. Okay, so what I want you to do now is, I know sometimes with like handouts people don't want to write on them, and that's okay with me, but I do want you to write it down. So if you don't want to write on your form, by the way, the form is in my workbook, so if you get the workbook, you can have lots of forms. But what you can do is write it down on a piece of paper, but what I'm going to have you do is you're going to break up into pairs. You're each going to have a turn to be the therapist and get the person to write down the situation that they just identified and what their anxious thoughts are. So related to that situation, only do the first two things. Don't keep going. Just do those first two things. But I do want you to write it down. And the reason I want you to write it down is because when you're working with a client and you're getting their cognitions, you want to get their words exactly. Don't just, because we can kind of filter it and think, oh, this is what they said. Really, it's attuning to what did they say. I want to hear exactly what they said and how they said it. So I want you to write it down. Oh, no. And think about those things. You want to make sure that, like, if they say something like, I might turn red, then say, and if you turned red, what are you afraid would happen? And then they might say, somebody would notice. And if somebody noticed, what are you afraid would happen? They might, like, laugh at me or think I'm weak, or just go down, just it's like a downward arrow, just 2 or 3 times to make sure you've got a good core fear. So what I'm going to have you do is, I'm going to have you break into pairs, make sure to write it down, and then you're each going to, so one of you is going to be the first, number 1 therapist. I'll give you like 3 minutes to do that. Then I'll say switch, and the other person is going to be the therapist, so that everybody will have a situation and anxious thought. Does that make sense? Any questions about that? Yes?
So who's doing the writing down, the therapist or the client?
Have the client write the thing down. So, yeah, you're going to ask the questions, but the client's going to be writing it down. Good question. If anybody else has problems or questions, raise your hand. So find a pair. You what?
Because I need somebody, because she just went.
Okay, do you need a pair? Right here. So any problems people had with that? Any roadblocks they were running into? Yes?
So sometimes in following the first thought and trying to go layers down to flush it out,
Yeah.
sometimes the thought in itself, the second thought or the third thought seems so much to explain why that would be a problem that sometimes it was a little hard to figure out how to go to the next.
Okay, can you give me an example?
Yeah. Mine or yours? Go on the microphone over. Okay. Oh, nice.
Social anxiety.
Here, it's secure right now. So,
Speak into the microphone.
yeah,
Thank you.
but I'm not speaking yet. Okay, so mine was doing a presentation in front of a group of professionals.
Yeah.
And then what would be the thought
Yep.
behind that would be feeling like I didn't know enough.
Excellent. And if you didn't know enough, what are you afraid would happen?
See, that was where it got a little hard. Well, people would think less of me.
Okay, this is good. So people would think less of you, and if they did think less of you, is there anything that you think, like what's the worst that could happen if they thought less of you?
Well, then it went to, well, people would think she's not a good therapist, never
Excellent.
recommend her.
Okay, good. So you'd want to write that down. So the people might think, if you didn't know as much as that you maybe didn't know that much and you're not that good of a therapist.
Yes, yeah.
And what's the worst that could happen if that were true?
Well, it came to a sense of, well, it really came down to the Charlie Brown thing when we talked about it, which would be like, then you're not in the club. You're not
you might.
cool.
Yeah, you might not be rejected a little bit. Beautiful. That's great. That is great. I mean, that sounds painful, First that's a super common. Seinfeld said that most people would rather be most people would rather be in their coffin than giving the eulogy. So that's a very common fear. And that was, in terms of the cognitions, you've really got some good cognitions there that we can then work with. So that was great. Any other roadblocks? Yeah, what? Yeah.
Feelings instead of getting with thoughts.
Thank you.
We had the word vulnerable.
Yes, exactly. It's hard to do much with vulnerable. So I kind of went over there, and so it was like, what was the situation again? Same thing. Yeah, speaking in front of others. So then it'd make me feel vulnerable. That is like so vague, we don't know what they're talking. So we need to get more. So I think I said, so do you have any images that would come to mind, or what things might happen if you were giving a talk? And then you said, I wouldn't.
I might make a fool of myself, or I might feel judged, or see, that's feeling. Judged.
Well, because what are you afraid would happen that would make you look like a fool or be judged? What images would come to mind? There you are talking, and what do you imagine might happen?
I feel like a failure.
Okay, and do you know any things that you might do that would make you feel that way? Like imagine you're talking in front of a group. Are there any images that come to mind of what you might do or say or act like that might make you feel like a fool?
Maybe that.
It is.
You're supposed to ask me a question, I don't know the answer.
Beautiful, beautiful. Now we've got something great. Because it's like, yeah, I might not know the answer when somebody asks me a question. And maybe I'll go, and then I'll look like a fool. Yeah, so you can use images. What images? Remember, when we're thinking thoughts, you can go to images. Images are thoughts. So what are images that come to mind when you imagine that? And then, as well as then you can get to feelings and fears, failure. Yes?
What are the interventions that you would use to work with these two examples?
Okay, so I'll get to that. For the cognitive part. Any other kind of roadblocks with that? Barbara?
Instead of the person wanting to go down with you, they want to go to more other things that happen, like, let's see, like avoiding a situation, like I just avoided, and because, how did this go? And I wouldn't, they're thinking about doing something, so then they just wouldn't do it. They just avoid the situation.
Okay, so we're not talking about getting the thought record, though, are we?
I guess we went into behaviors. What would happen?
Yeah,
And then we
okay.
got into behaviors.
Okay, yeah, so we're not there. Yeah, so this is just about cognition. So just being able to get a good cognition, making sure that it's specific enough and not too general and it's not a feeling. So that's what we're trying to get, very specific. Any questions specifically about that? Yes?
Yeah, what comes to my mind is that isn't really where it started. It started when I was little, so the situation would be something when I was
That's fine.
small.
Absolutely.
And not relative to the distortion at the time. So I'd be afraid because Mommy might slap my face.
Okay.
You know.
Okay, so that's fine. That's fine. So if it's that, like, in terms of the situation, it can come from, and sometimes we'll ask, do you have any memories or images related to this? That's fine. So you want to flesh that out so we can kind of maybe understand where it came from. And but here's the thing. First of all, I'll tell you guys something. I mean, doing only anxiety disorders, of course, the first thing is trauma, trauma, trauma. No, 85% of my clients have not had any big T traumas, but they have major anxiety disorders. So that's just sort of a little bit of a myth, that anxiety disorders are caused by trauma. Oh, I'm talking fast. Did you guys hear it? Ooh, okay. So, yeah, then if there is trauma, not a problem. We want to know what that is and how this might have happened because, yes, oftentimes there is something that tripped them into this disorder. But what we're looking at in CBT, this is a common misconception, maybe it's why I was talking fast, is that we're looking at what's maintaining the problem now. We are very aware, we want to honor what started it, and you have good reasons for doing what you're doing. Good reasons. But right now it's interfering with your functioning. So we have to figure out what is now maintaining it. Because just like Justin and the dog, he had a trauma. He was chased by a dog. Now he's generalizing that to all dogs. This is a problem. It's interfering with his functioning. So we have to start changing that behavior pattern that's maintaining it, the cognitions and the behavior that are maintaining it now. We honor that this is what happened, and it's important to know that. And he's doing it for good reasons. He shouldn't feel shame that he's running into the house, but it's not working for him. Does that kind of make sense?